at MSFT today, and we're joined by the wonderful Sarah Haynes, who's Head of Patient Experience. So Sarah, I'm going to hand over in a moment to Sarah. She's going to present some slides to us. What I'll say is if anyone's got any questions, we can leave those to the end by raising your hands metaphorically on the screen. If anyone's like me that thinks of questions as and when, by all means pop them into the chat, and then we can circle back at the end, go through any questions in the chat, and then we'll go to the live questions if anybody has anything to say. If we do happen to run out of time and there are outstanding questions, Eve will kindly pop into the chat in a moment the email address for you to email any sort of outstanding questions you may have. We'll signpost them to Sarah to try our best to get an answer back to you. So without further ado, I'll hand over to Sarah.
Thanks, Tony. Thanks, everybody. Good evening. As Tony said, my name's Sarah Haynes. I'm Head of Patient Experience and Engagement at Mid and South Essex Trust. And the team have invited me along today just to talk a little bit about what we're doing in patient experience and engagement and some of the things that we'll be doing, particularly moving forward into this year. So as Tony said, if you could pop your questions in the chat, that would be great. Bear with me with my technical. I'm going to try and share the screen now. So if there's any issues with that, I do apologise, but I'm going to share my screen now. Go. Is that okay, Eve? Does that come up all right? Yeah, I've got some
Yes,
nods.
I can see that.
Thank you.
I can see it.
Fabulous. So we'll get started. Thank you. So patient involvement at MSE. Said who I am. My background before patient experience is that I was a nurse. I've been a clinical nurse specialist and a matron at Southend Hospital and MSE. And then I moved towards the more governance side of things, working in experience and engagement. So I'm really, really privileged and excited to talk to you about that today, and how patient and community involvement is shaping care across our hospitals at MSE. So who are we? So you might have heard some of this information before with other presentations, but as you may know, we're one of the largest NHS trusts in the UK. We serve a population of around 1.2 million people. That's served by around, again, 15,000 members of our staff of all different professions. And we have sites at Basildon, Broomfield, Southend, Alsett, St Peters and Braintree, and we also have lots of other satellite sites that are sat in little clinics across the patch. So what do we mean by patient involvement? So we define it as it's not a one-off exercise, it's a way of working, it's about listening, partnering with people, co-producing improvements with everybody that uses our services, and it's about moving from what we do to people to doing with people and doing with our communities and with our patients and our families and our carers. So it means listening to our patients and families. It means working in partnership to design, improve and evaluate services. It's ensuring voices influence decisions at every level. And as I said, it's moving from doing to doing with. Why it matters, you may ask. So when patients and families are involved, services improve. We see better safety, better communication and more responsive care when we involve our community. And it also helps address inequalities because we can't design services that work for everyone if only some people are involved and some voices are heard. So we aim to improve our quality and safety and experience of our services and hope that it leads to better outcomes and experience. It helps services reflect what our local needs are and our local diversity is. It builds trust, accountability and transparency, and it reduces inequalities by hearing from underserved groups. As you can all imagine, because we are covering such a large part of Essex, each of our hospitals, we might all access them as members of the community, but they're also located in different places that have different members of their community, different populations that we serve. So in Southend, we know that we serve a more older population due to the location of where we are and where we have a lot of care environments. We know that Basildon serves a population, a much higher population of people from a Roman Catholic background than any of our other sites. We know that people in Southend are using, let's say, more translation services for people from Poland, for example, or India, various different places across the world. So we're trying to reflect the populations that we serve in the meetings that and the work that we do. So at MSD, we're committed to co-produce with our patients, carers and our communities. At the moment, we're working really hard to make working with people, working with our communities, part of everyday life for all of our staff, so including it in trust policies and trust governance. Governance is about how we manage things within the trust, so it's making sure that patients and communities are involved in important decision making and understanding how we're going to change and shape services in the future. We use feedback to drive improvement all the time. It ensures inclusion for everybody across the community, and we support staff to deliver personalised and compassionate care. What we want the feedback from we want feedback from the ward to enable our staff to shape strategic decision making and embedding involvement into clinical governance and quality improvement. This slide might be a bit more familiar to you in terms of some of the work that we do engaging with people. So we gather insight in lots of ways. We have the friends and family test. Some of you may be familiar with that. If you have an appointment or if you have, if you're admitted as a patient to one of our hospitals, you might receive a text asking how good the service was, and that's called our friends and family test. And we have over 250,000 responses across a year period across the trust in terms of feedback from our friends and family. We obviously collate how many compliments we get. We also have a complaints team and our patient and advisory liaison service teams as well, where we get a lot of feedback. Some of you may be aware that we present patient stories to our board and to our different governance groups. We take part in national surveys that are headed up by the CQC, which enables us to benchmark against other trusts, but also to get a more independent assessment of our performance. They focus on particular around emergency care, maternity, cancer services and inpatient services. We have recently reinstated our carers steering group, our accessible information standard group. We are increasing the amount of community outreach and events that we provide at the trust using digital feedback platforms and improving how we co-produce with our communities. So one of our new groups is our carer steering group, and obviously carer and family involvement is essential to being partners in our care. We want to ensure that our carers have a strong voice and that we're improving involvement in discharge, accessing to information, staff awareness training, and that includes our accessible information standards. And also part of the team, we also, I manage, for the want of a better term, our chaplaincy services. So on each site, we have chaplains that work to support our staff and our patients who are currently receiving services at the trust. So I also look after them as well. So I wanted to give some examples of how we've used co-production to change the way that we work at the trust. So co-production is involving our community, our patients and their carers, involving them in decision making and getting their feedback to drive the way that we want to change things. So some of these examples were We redesigned the discharge information that's given to carers based on what the carers fed back. We weren't including everything they needed, so we used their feedback to put together leaflets for other carers on discharge when their relatives are being discharged from hospital. We work on the development of new patient information leaflets from people that have that speciality or receiving care in those areas. And we have a reading panel as well, who are our group of volunteers that read our patient information and give us feedback to make sure that it's not too full of NHS lingo, and to make it easy to understand. We've done a lot of work around co-producing pathways for people with dementia, people with learning disabilities and autism across the trust, using patient feedback to inform our ward communication boards. We've recently done a big piece of work with young people in our paediatric environment. So we did some walks around the paediatric outpatients and inpatient areas on each site with some young people giving us feedback about the environment, how it made them feel, how we could improve the environment in paediatrics. That was really successful, and they gave some really honest feedback, particularly around, as you can imagine, paediatrics is quite difficult if you're a teenager. You're not quite old enough to be in an adult ward, but you don't also want to be in a ward full of babies and toddlers running around. So we got some really valuable feedback from our teenage patients that our paediatric services will be using in terms of redecorating areas, making sure that there's play areas for young children, but some chill out areas for our older children as well. We work with our community groups advising on accessibility and inclusions. We work with Essex Cares. We work with the Royal National Institute for the Blind and people with hearing impairments, things like that, to improve how they access services and how we can provide a service for them. I've talked about the leaflets, and I've talked about our chaplains as well. At the moment, we're reviewing our chaplaincy services to try and make sure that we meet the needs of the groups on each of the sites appropriately. So how feedback drives improvement, just some more examples there. We've improved our menus, we've improved our discharge communication, things like our signage. Health Watch Southend helped us do some assessments around the signage. For any of you that have been on our site, it can get in a bit of a cycle of where we're moving things and our signage isn't catching up with it, so it's really important that we get that feedback. We've improved how we provide British Sign Language for people who are hard of hearing. We've improved staff communication training, updates to our complaints and our PALS processes, redesigning waiting areas. So lots of opportunities to change the way that we work at the trust based on what our patients are telling us. So there's lots of ways that you can get involved. We have patient and carer groups. We have community panels and listening events throughout the year. We have more bespoke surveys that are around specific departments. For example, we've done some work with our renal patients around those services. You can share your experiences via our PALS or our compliments or complaints teams. You could become a patient partner or volunteer. You can get involved in specific service redesign projects and helping us co-produce new materials or new pathways. We're at the moment in the process of redesigning how we work with our communities and our patient partners. So I know I've got some excellent support on the call of people that have been really supportive in our current patient experience group. We're tweaking that to improve how that monitors experience across the trust and how we can make tangible change. And there will be more as the opportunities arise. Eve's been kind enough to help me use the mailing list for you guys. So when opportunities arrive, we will be using Eve to email out requests for help. So if you are interested, please look out for those and feel free to volunteer. We'd love to hear from you. We promise that we'll listen, that we'll act on what we hear, that we include diverse voices, we'll be transparent, and we'll work in partnership. and we'll strive to keep improving. And then the last slide is about how to get in touch. So I think I'm going to be quiet. I'm going to take a sip of herbal tea, wet my palate and wait for some questions.
Thanks, Sarah. That was really insightful. Appreciate you taking the time out this evening to go through all of that. Okay, so there's no questions in the chat, which is fine. So does anybody have any questions for Sarah at all? I don't. Mary and Phil, hello.
Yeah, hello. I'm Philip Davis and this is my wife, Mary. We are on the William Fisher Medical Centre patient group, but I'm 82 and at my advanced years, I've had to use the health services quite often recently. I'm a cancer patient and a kidney patient and a diabetic patient. So I've had to use the services of the NHS. And honestly, every department that I have used over the last few years has been absolutely excellent, except for the pharmacy. Now, often when I go to chemo, the nurses tell me the medication that I normally come away with after my chemo hasn't been sent up from the pharmacy, and I've got to wait 1, 2, and I think the pharmacy services to the general people who use it anyway from the hospital, you know, where they go down to the pharmacy, but my drugs come up to the ward, and you know the nurses on the ward are very busy, really excellent service. I can't rate it more highly. And they say, you know, we keep on having to chase up the pharmacy to get the drugs up. And it's one area of the hospital services that is I think is really appalling. And if you've been on chemo for several hours and then you've got to wait another 2 hours to go home, and I live on Burnham on Crouch, which is 3/4 of an hour's drive away.
Yeah.
So I can't go home and come back.
Yes.
You know, it's not economic. And you know, when you've had chemo, you don't really want to do the travelling anyway. But you know, it is the one aspect that I think needs improvement. And I've reported this through the survey that I get each time I use the service, and I've also reported it to PALS. And I actually did get a response back from somebody at the pharmacy, and all they did was blame the nurses for not doing the order in time. And you know, I said, well, I'm sorry, but when I have medication that is not normal, you know, the doctor there has given me some additional, and I have to have it from your pharmacy. I can't get it from my local pharmacy. And I go down there. It's a long way from the chemo unit, and I've got mobility difficulties. And I had to sit there for 3 hours to get the one item that I could have got from my local pharmacy. So, you know, this woman who came on, she was really not very helpful at all. You know, she was blaming everybody else and blaming, you know, the problems that they've got. And it wasn't the sort of information I wanted to hear. I wanted to know what actions were being taken to improve the service rather than complain about everything. So, you know, I'd rather have somebody more positive regarding, you know, what improvements will be and can be made.
Thanks, Philip.
Sorry about that.
So you don't have to apologise. Thanks, Bill. And from a personal perspective, I had chemo myself at Southend 2 years ago. So I know I've been where you are, where you were talking about, where you're waiting for your medication to be sent down to the chemo unit so you can have your treatment for that day. And some of it is, like you say, it's very time dependent. Obviously, I don't work in pharmacy, so I couldn't give you specific answers. From my perspective, I do know they're having a big recruitment drive in pharmacy. When there are a lot of vacancies, that does impact anybody's ability, obviously, to make sure they're doing their job well and in a timely fashion. But I'm sorry that that was your experience. I will take it back to our pharmacy leads and see if there is any other work that's going on, particularly for our chemo patients. Would you, if you don't mind me asking, Phil, did you have your chemo at Southend? Because Burnham, you're a bit in the middle of everybody, aren't you?
No, I'm on the chemo day unit at Broomfield, and it's
Broomfield.
absolutely excellent. I can't rate it more highly.
Yeah.
All the staff, everybody.
Thank you for that, and I'll feed that back to the chemo staff as well. But absolutely, point taken, Phil, around the wait. And I think pharmacy waiting when you're discharged as well from an inpatient ward has been an issue in the past for some people. And I know particularly how disheartening that can be at 9 in the morning when you're told you're ready to go home, and then at 4 o'clock in the afternoon you might still be waiting for your medication so that you can go home.
My wife has experienced the problem where she'd been discharged around about 1 o'clock, and she's still taken up a bed, and the nurse actually had to go down to the pharmacy just before they closed at 6 o'clock before she could get the medication to discharge my wife. And that is appalling when, you know, people are blocking beds and we want to get people out of beds. So it's really important that somebody does something about it.
Absolutely.
Because it's an additional burden on the nurses, who are really hard worked anyway. And they provide an excellent service. I just can't praise them more highly. Yeah.
Thanks, Phil. And you made an important point about how it impacts on the rest and what we call it as flow in the hospital. As you say, Mary may have been still waiting in a bed, and that may have been you. So we are looking at lots of different ways that we improve the flow, and particularly this week we're looking at corridor care and trying to reduce the amount of patients that are waiting in the corridors for beds. And getting your medication if you're being discharged is really, really important because it frees up that part of the pathway. So although I can't be specific with the actions, I do know that there's, particularly this week, a lot of focus work going on around to improve that. But I will feed that back. Thank you ever so much.
I think the service is for taking the drugs to the ward. That part is okay. I think they've got volunteers and people doing that, but it's the actual pharmacy unit that is dispensing the drugs that seems to be the blockage.
Yeah, absolutely. Thank you.
Thank you. Alan and Eric, I know your hands up. So go to quickly to the chat, if you can bear with me. So there's a couple of questions there. So there's one from Solomon saying, I understood your experience and down to the lack of decision making within the organisation to improve their safety, their staffing level rather, lack of investment. I think it's a bit of a tough one for Sarah to answer, really, unless you want to give it a crack. But we are working hard to try and get the staffing levels to where they are. Sarah?
Yeah, so in terms of the staffing levels, particularly in pharmacy, that isn't about a lack of investment. So the roles are there, they are vacant. I think, unfortunately, across the patch, including nursing, lots of vacancies we struggle to recruit to, even though the money may well be there. But that doesn't mean we stop trying. And I know our pharmacy teams and our nursing teams alike try to think a little bit more creatively and see if there are other ways that we can work to bridge that gap. But yeah, it's a bit of a broad answer, but that Solomon, but that's obviously the position I'm in at the moment. But yeah,
Thanks,
certainly
Sarah.
in pharmacy, those staff it's just the recruitment part of it and getting the bodies, getting the people in.
Thank you. And then we've got one from Pat. Mike's not working, so I'd like to say my treatment is great, but there's no tie-up between the different hospitals, and trying to get results is difficult.
Yep, so we hear this feedback. So there's a couple of things that are going on, and Tony, if I miss any points, you'll hopefully be able to sort of complement this. But in terms of our 3 sites, we all have different computer systems with our patient, what I'll call accounts on. We are currently involved in one of the biggest projects for patient records across the country in partnership with Essex Partnership Community Trust. We are having a new patient record system. That means that if I'm at Southend, someone at Broomfield will be able to see my letters, my blood results, my x-rays without going into different systems. So moving forward, that is going to improve. I believe the first part of the go live date is about a year from now. As you can imagine, it's a mammoth task, because we don't want to miss any departments out. It's really important that when we move over, we get everything correctly. But in terms of that will improve. And if I can also make a plea, and I can happily share it out to Eve afterwards, for those of you that are able to have the NHS app and the Patient Knows Best apps on your phone. So these apps will then send you your blood results once they've been approved. You will get your discharge letters from them quicker, and it comes straight to your phone. So if you're able, that's such a great way of improving communication with the hospital.
Thank you, Sarah.
Just on that point, could I say, I've got both the apps, the Patient Knows Best and the GP one. The GP one is fine. I can see all my notes, all my test results and everything. But the hospital, all I get, and I being a cancer patient, I need to know the state of certain blood conditions.
Yes,
that
yes,
affect
absolutely.
And I have to ask the nurses to print me one off, because the tests never get put onto the Patient Knows Best. There are 2 consultants I have who do put my appointments on there, but nothing else. So I'd really like to see the Patient Knows Best get up to the standard that the National Health Service GP information is, because that is very good. I can see all the consultation results and everything else, test results, make appointments, but the hospital side is terrible.
So from the Patient Knows Best perspective, we're at the beginning of that piece of work, and you will see that more and more things will start to become apparent. We can now see, for example, I got my mammogram results on there now, where you couldn't get those a few months ago. So the system's not perfect, and because it's so big, it's being done in stages. At the moment, you might get an appointment, it won't actually say what site you're on. So we're picking up these problems, we feed them back to the team straight away. And we have got some patients that are part of the PKB and the Nova groups, so that we're making sure we feed this information back. But please bear with us, the blood results will come. It's just building on that system. As you can imagine, there's a lot of stuff that it has to go through, and we don't want to put blood results on there too soon either, because obviously we don't want people to have access to information that might be, for example, bad news without a doctor or a nurse being there. So they have to be screened as well. But we're in the process of doing that, please be assured. Bill, thank you.
Thanks, Sarah. Alan, thank you for waiting.
It's okay. Sarah, I've had a couple of people approach me as a governor at the trust about issues with communication, particularly where they've had elderly parents with various elements of dementia. And I heard you say that you've been co-producing pathways, for those with dementia. Could you tell us a bit more about that? Because obviously it would help me respond to those sorts of questions that probably lots of us get.
So in the presentation, when I say we, I mean the trust. So for dementia, we have a team of dementia nurse specialists. We have one on each of our main sites, and they work with the ward teams, for example, to support people with dementia. But in terms of the quality improvement side of things, there is a national annual dementia audit, and they look at the results from that to try and make changes and improve the care for people with dementia. The communication part absolutely is key. We can put things in place, not everybody follows them, so it's important to keep reminding new staff, old staff, that to keep in communication with the named relative or the person, the carer, you know, that the patient wants to share that information with. So yeah, our dementia, there are dementia nurses on each of the sites. so they can be approached for support as well. If there's any more specific questions, we do have a patient engagement email. So if there's any questions like that, we can always pass them on to our dementia nurses to get those answers for you if there's anything more specific.
Right, that's well, two things there, but that's interesting because I didn't know about that. So I wonder how many people do know about that, that you can directly email the patient engagement team about these issues. I have met one of the nurses at Basildon several years ago. I did a course and she was really good. Yeah, I was trying to remember her name, but anyway. But what I'm interested in, these people were struggling to know who to talk to on the ward. This was when these people's relatives had been admitted. And as governors, we've been dealing with issues about communication for nearly a year now. And what I came across was the same old issues, of how to communicate with the ward, how to communicate with the hospital. One of the two people I talked to actually came into the hospital in the end.
Yes.
Which is the last thing I think they want and you'd want. But how that process works at the patient level, you're talking about trust level, and policy and so on, which works well. But how does it happen? How do you ensure it works in the ward for every patient and every family?
Really tricky. Communication is the biggest theme in the NHS for where things can be improved, because it can mean so many things. It can mean you're trying to ring the ward and the phone is ringing and ringing and ringing, or you're trying to ring a department and it's ringing, you don't get answers. So there's that side of communication. There's the letters side of it. In terms of the ward, the person to speak to on a day-to-day basis would be the nurse in charge of that ward if there was day-to-day issues. Before going to PALS, before coming to patient experience, always speak to the ward directly. There are also rules that we have to follow that are really strict. So if the patient is able to say, I don't want you to talk to those relatives, they might not always tell the relatives that, but we have to be discreet as practitioners with what we share, because we have to have the patient's permission to share that information as well. So sometimes that can make it a little bit more complicated, depending on people's level of dementia. So some people can be in early stages of dementia and still absolutely have the right to keep their information private and make decisions about themselves. But as we all know, there are people with advanced dementia who really do need that family support. We do have a document called a carer's passport, and you can complete that as a carer of someone with dementia or a learning disability, for example. That can be completed, and if your person is on a ward, it's almost like a mini contract. So if Fred's my granddad, he's been admitted to Balmoral ward, I can sit down with the nurse in charge and say, as this person's carer, can you make sure you call me if there's any changes to the medicine, for example, or if they've had a fall, or if you need more support with what they want for dinner. So there is the communication pass, the carer's passport, that can be set up with the ward.
Okay. Sorry, I need to speed this up, obviously, because others want to talk. But I've got a 99-year-old dad with some dementia. I also have power of attorney for his health. So how does that interface with this? And if there's a patient passport, why do the two people who talk to me about this situation not seem to know about that? So what I'm saying is, the interesting thing about this is not the system, which looks fine, but the implementation of the system and the monitoring of the system by the management. That I'll raise that, I'll leave that. I don't expect you to answer all of this at this time, and I'll let Eric go on, because he's getting very impatient. He's an old friend.
That's okay. I think meetings like this help us spread the word. I can't speak to 1.2 million people.
No, I get that.
So as communities, we all spread the love, we share the word, and through pieces of work like this, things about like the carer's passport, we work with Carers First, we work with Health Watch, they help us share that kind of information. as a patient, we have a responsibility to look for information like this. So if you're we've got a learning disabilities passport that helps people with learning disabilities cope better and express their needs in hospital. But yeah, it's an forever cycling journey, Alan, on keeping everybody informed. If anybody's got any suggestions, I'm always open to them, because it is really difficult keeping up with everybody, as you can imagine.
I think it helps if the governing body knows a bit more about that. That would be useful. But
absolutely.
So there's some more conduits. I'll shut up.
It might be that we use the newsletter that you guys have for the members to start promoting some of the work as well. I think that would be a good tool for us to use. So I'm sure that Eve will be open to us working on that. Thanks, Alan.
Thank you both. Eric, good to see you again.
Hello, thank you.
Over to you.
Nice to see so many old friends, and very nice to hear you, Sarah, just mention Health Watch, because that's one of the points I was going to make. It appears to me you've got a huge amount of work. I don't know how many staff you have, but I've been very impressed. You may know that I launched a prize with the Royal College of Physicians for hospitals that excel in patient engagement, and Guy's and St Thomas's have got a wonderful programme, and I spoke with them. There are about 20 of them, so it's maybe you need more people. And the other point I would like to make is that with my cancer background, I've been aware of a number of small cancer groups. There's one in Brentwood I used to be part of, there's other ones, and I don't think they feel sufficiently included, which is a bit strange because the cancer nurses come out and talk, radiographers come out and talk, but apart from that informal connection, they don't seem to be part of the family. So that's my point.
Thanks, Eric. It's lovely to see you too. In terms of the cancer, our cancer services have an excellent patient cancer champions group, and they are very, very proactive with informing what the action plans are and the cancer strategies. They're very much involved. So there are lots of opportunities, but again, it's about that communication. So I think for me, if there's any big piece of learning from today, is that I'm going to link with Eve more around how we can make the most of the newsletter to share all of this great work that the teams are doing.
And Eric, sure you're not working.
Eric, there's only 3 of us, so if they've got 20, if there's 20 there, I'm very jealous.
Okay, well, I hope you get more soon.
Thanks, Eric.
Hi, thank you for your patience. We've got Councillor Maxine.
Well, thank you very much, Anthony, and good evening to everybody. And also good to see Eric again. Just on the communication, it's great about the newsletter, but also please use our South End City Council comms. You could any communications you could we can get out to many of our residents as well. So we'd be happy to do that, I'm sure. Thank you.
If I email you, Max, and you could send me the contact details for that, is that okay, Max?
Yeah, that's fine. Yeah, that's fine.
Perfect.
Yeah.
Thank you. Just writing my little jobs list down. Sorry.
Thank you. Apologies, the camera's gone off. It's I've got a bit of a bad connection, so I've tried to turn the camera off to see if it speeds things up. So bear with me. Richard, your hand's up.
Yeah, hi everybody, thank you. So first one of these meetings I've been to, so thanks very much for the update, Sarah, very interesting. I had a quick question around phone numbers. So I've got an example of getting a letter from the NHS, from the Trust. The phone number on it was a deadline. So I went through the switchboard. The phone then rang out for a while, which I understand actually, because people are providing care, so I'd rather they did that than maybe answer the phone. But it then goes through to somebody's personal voicemail rather than the department voicemail. So then I think people are left wondering whether actually have I got read through to the right department? Have I left the voicemail in the right place? So yeah, I just wondered if that had been raised before or if that was something new.
Unfortunately, Richard, it's been raised before. I'd like to say
it might have been
new, but it's not, particularly because we've changed all of the phone numbers as well. And then, as you can imagine, the stationery might not have caught up with the change of the physical phone number. We acknowledge that this is a big issue. A lot of work's been going on in the background. We are trying to remove unnecessary answer phones, because we don't want an answer phone facility if there's actually nobody that's listening to them or responding, and it sets us up to fail, and it leads the patient to falsely believe that they've left a message and someone's going to get back to them. So there has been a huge amount of work around that. And I know Chris, who's on the call, Chris Gasper, he comes along to one of our patient experience groups, and we've invited the leads for that to come along. They are making progress. We are changing, making sure all the internet, the intranet, the stationery is catching up with the new numbers. So I can only apologise. But again, if you see an issue, if you email our PALS team, we at least know then, right, we'll target that one. We can send that to the owner of that phone number and target them specifically to make sure that it's changed. So please don't feel like you're bothering us. It does, obviously, those little things help us make those bigger changes, but we hear you and we do know it's an issue. So we're actively working on that as a trust.
Brilliant. Thank you.
Thank you, Richard.
Thanks, Richard. Thanks, Sarah. Paul.
Good evening. I've had a similar problem that's just been described. My wife had a urology scan over 2 months ago. It was one of the radioactive ones, and she has not received any results. Now, when she contacted her GP, the GP said she had to phone the hospital. When she phoned the hospital, same result. We had an answer machine, and then she was left on hold for about 10-15 minutes, and we're still waiting for those results. The other thing I'd like to raise is that in the past at Broomfield we had an organisation called Patient Council, of which I was vice chair. That since the merger, that seems to have died to death, and it's unfortunate because I spent a lot of time training new recruits, all of which are now redundant, shall we say. And the beauty of the Patient Council was that we could actually go onto the wards unannounced, speak to patients, and very often we could solve some of their problems. I, for instance, had a lady in tears because she'd been told she couldn't have any post treatment or care after discharge because it was a non-elective, it was an elective surgery. This was absolute rubbish, of course, and I was able to contact the head of nursing, and we got her that help within 48 hours. Now this thing is completely died, and I wondered whether there are any chances that it might come back to life, or is it regarded as no longer necessary or useful?
Thank you, Paul. And absolutely, I hear you in terms of the work that the Patient Council did, and it's evolved over the years. So rather than have a dedicated Patient Council, what we would rather, and what NHS England recommend now, is that we have patient representatives involved in alongside the staff. So if we're working on cancer, we want people that have got an experience of cancer on that group, and that's how the Cancer Champions group has grown. We have different audits, like you say, about going around talking to patients. We still have those in place, but they're done alongside our nursing teams or our estates teams, so that we can pick those issues up immediately, and that the patients and our communities are represented at that point. We also want to make sure that our services are reviewed by people from all different backgrounds, and sometimes the traditional Patient Council routes may have excluded people from different backgrounds, not deliberately, but just sometimes the way that things are set up. So the jobs that the Patient Council did are still picked up, but rather than being a separate entity, they're now part of the team that are working on that. So as I say, the cancer one's an easy one for me to give an example. Instead of having a separate Patient Council, we've got patients on those steering groups actually where the work is happening and involved regularly. So it's a bit of both. We've kind of evolved that patient council to be involved in different ways, Paul. Thank you.
Well, that may be all well and good, but some of the things we dealt with on the patient council were things like noise at night, and which I don't know whether you have a specialist dealing with that sort of problem. Then we have problems with dietary requirements, or the failure to answer call bells, all of which we could raise. But if you've got a specialist dealing with just one discipline, I can't see how that broader spectrum can be addressed.
So those things are picked up. What we do every week, our director of nursing on each of the sites do ward walks. On those ward walks are members of the patient experience team and volunteers who go round and ask those questions, and that's fed back through those ward walks alongside the director of nursing, the ward manager and the sister. So the work is done, it's just in a slightly different format, Paul. But exactly those things like noise at night, we still see as an issue. So we pick up things about lighting, trying to improve that, trying to improve the times that we do drug rounds so that they're not too late, for example, and disturbing the patients. So please be assured that those things are captured. It's just in a different way now, Paul, to make it a little bit more inclusive.
Okay. Thank you very much.
Graham. You're on mute, Graham.
Apologies, can you hear me now?
Yeah, gotcha.
Oh yeah. So this is the first time I've attended one of these meetings as well as Richard. So one of my concerns is in Southend Hospital around the physio department and around the communication in there. This is from my own experience because I've just had a knee replacement, so I'm having lots of physio. And I'll put past some of the other issues I'm having, but the main one was around communication and the information on the cards. There's a number to call. That number is not active. It is not active. So when I went to reception and said, I tried to call that number, it didn't go anywhere. And then I called the reception number and they said they couldn't put me through. And they said, oh yeah, that number's not active. I was like, well, why are you still issuing that number? Why can't you cross that number out or reprint those? And no one seemed to think it was an issue.
Right,
but it's definitely an issue for me.
Graham, sorry, Sarah. How long ago was that?
So that would be probably 4 or 5 weeks ago. I'm having weekly.
I don't suppose you've still got that print out, that number. Just pop it in the chat for us because
I haven't.
Okay.
I think I threw it away because I was.
Why not? Yeah. Why would you keep it?
Yeah, I mean, I just couldn't believe that they were, when you get your card number and they write on the back the date and time when it all is, those things, and also the letters. And it's like, why is that number on there? And you're not communicating that out. Even the receptionist could just cross it through. Just say this is not active anymore. So that was very, very recent.
Yeah, completely hear you, Graham. I'll pick that up with our physio team. But if you do find anything, let Eve or Tony know. But I'll pick that up with them. And it is something we're experiencing across all of the sites. And as frustrating it is as us for patients, some letters are printed off automatically and a person doesn't necessarily read them, which isn't right. It's not acceptable, and we do need to catch up with our communication. So please don't think I'm making excuses.
No, it was okay. It was just I was driving round and round trying to park, and you get half an hour, and I was over half an hour. I'm like, I can't park now because I can't park, so I had to leave. So I wanted to call to say, look, I did not show up. I just couldn't park. I couldn't, and then I emailed. To be fair, after that point, to be fair to them, I found an email and I emailed them, and someone replied.
But thanks to you for being so tenacious about it, because not a lot of people would have been able to do it or would have done that. So
most people rely on the information they're given with a number.
Absolutely.
The bold is quite a bold number. I'm just shocked that they said, oh, it's not active. It's like, wow. Okay.
Yeah, without saying thanks a lot, let me feed that back to the department. That's what you want to hear, isn't it?
Yeah.
Because we do make mistakes. We're only human, but actually what you want to know is that somebody's going to do something about it for you.
Yeah, I
And
mean,
absolutely.
I'm back there Monday. I will ask for a sheet to put my appointment on there and see what one they give me.
Yeah, do a test
See,
for
and
me.
see if it's still on there.
You can be a secret shopper for us, Graham. Excellent.
Thank you.
And thank you.
Thank you both. Was there any more questions from anybody? I know there's a point made. I don't know if we can put the patient engagement email in the chat for everyone. Would that be possible?
Just doing it now.
Wonderful, thank you. Did anybody have any other questions or anything they wanted to get any sort of insight on, or anything, any answers to any questions anybody may still have?
Tony, I could ask a question. What's the name and address and office space of the person who decided to change the phone numbers? I mean, and why? I mean, I've lived where I'm in a room. I've been here for 41 years. I know I'm not a business. I have had no need to change my phone number. And that would create a limited amount of mayhem. This is exactly what I've been talking about for a long time. Who made that decision? And can I watch them fall on their sword? Because it's brain dead.
I absolutely understand, Alan, and I'm not techie enough to give the proper explanation, but it was to do with
want you to.
It was to do with new systems. And even so, I'm in my desk at work. It's all very high tech. I haven't got a phone anymore. Haven't got a physical phone. My phone comes through on my laptop now. I make calls via my laptop. So that was something to do with changing the numbers, and that's kind of my best effort. I imagine the chap that did it is probably not sharing his address or his phone
Let
number.
alone his phone number.
But
or his phone numbers.
If I see crowds of people with flames, I'll perhaps guess that they're chasing him.
But we have had so much of this issue, yeah. And I visited an office in Basildon when we last did a patient sort of experience trip, quality and safety visit, and the people were in that office were making appointments, and they were perfectly aware of what they were being asked to do. Why on earth? I mean, computers are very clever things if you tell them what to do. And we haven't reached the stage yet where they do it by themselves, mostly, not on the NHS anyway. So I just don't understand. Anyway, enough from me.
I hear your frustration, Alan. I feel
it's not me, it's other people.
It's all of us. It is. It's all of us. And even as members of staff, we have to get through other departments as well. So, but I do know that it is revisited regularly because of the constant feedback. So.
Thank you.
Thank you. I'm conscious that we were 6 minutes out. I just want to get Paul's got his hand up.
You're on
Paul,
mute.
you're on mute. Yeah.
It helps if you switch the microphone on.
Thank you.
I'm back to my original point about getting results from various procedures. Is it reasonable to expect a patient to wait for best part of 2 months to get a result from a procedure they had carried out? And why is it the fact that her GP has not been informed of those results?
Is this in relation to your previous question, Paul? Just conscious.
It would be a generic answer that they won't have been scrutinised from this end, I imagine, and that's why they're not shared, Paul. But it would be very difficult and remiss of me to give a specific answer to that. As you know, the NHS, we have got waiting lists, and that's across from our labs, from our consultants, from all of our staff. So I wouldn't. It's not acceptable. We would like to improve that. And I know, for example, our cancer teams are always trying to improve their targets to make sure these things do reach people in a timely fashion. But yeah, I can't answer that specifically, Paul. Apologies.
Well, can you at least raise it somewhere? Because I don't feel that waiting 2 months for the results of a test is not reasonable. and can cause concern because it was being a radioactive procedure. It was obviously of some significance. Previously, when she'd had a scan without the radioactive material added, she got the results within about a week, which is reasonable. I mean, if you're going to want to plan holidays, for instance, if there's something major wrong, you want to know so that you don't waste your time making an appointment for a holiday.
Of course. Thank you, Paul.
Thanks, Paul. We've got 3 minutes left. I will make Danny the last question.
Hi there.
Last word, Danny.
Yeah, can you hear me okay?
Yes, thank you.
Good, okay. So first of all, I do apologise. I was trying to get through earlier, but I couldn't get the sound going. So long story short, having got over that problem, I'm now talking to you on my Chromebook. So good afternoon and apologies for missing half the meeting. Yeah, I've got 2 things that I want you to raise. One is a matter of a local issue, and maybe if I explain that one first. The local issue is the Langdon Centre. Now, I understand that the subject has been well and truly raised, and that the authority, as it were, believed that the scheme that was being put forward was too expensive. Now, I can only assume that that actually was part of the actual plan that was, well, it's been in course now for some time, let's put it that way. And meantime, of course, the Langdon shopping centre is being built, and the Langdon Health Centre is still what I would call somewhat ancient now in New Town terms. There has been suggestions that maybe that be improved, which will be difficult, but I can understand logistically it's there, and so therefore that would make some sort of sense. There was a harebrained scheme to have it the other side of the high road, which thankfully got blown out of the water because that was completely unacceptable from a point of view of logistics of car parking, from the point of view of the only one way that could go would be upwards, and it wasn't really a suitable place, and eventually people caught on to that. So my question now is, what is the current plan for the Langdon Health Centre? Now, I understand that obviously there'll be negotiations between the various authorities on it, but could you just tell me what the latest is? Because everybody is very frustrated, and as you know, that this question has been around for about 6 years. So is there any updated, apart from the knowledge that it's been turned down because the plan that had been put forward was too expensive? So the update on that, if there is one, please.
So apologies, is the Langdon, is that a GP centre?
Yes, indeed, yeah.
So that doesn't sit with Mid and South Essex Foundation Trust. So as the hospital trust, we wouldn't have any involvement with the GP services. That sits with the integrated care services. So it's nothing to do with us as a hospital. So I wouldn't have any information about that, I'm afraid, Danny. Apologies.
So it's not Mid Essex or Hospital Trust?
No, it will be Mid Essex Integrated Care Services.
Oh, well, there you go.
I know. They look after GPs.
Yeah, okay. All right, okay. I understand where you're coming from, but you seem the obvious place to try. Okay, so the second point that I want to talk to is personal to my wife in particular, and she has had problems with her eyes. And I'll cut a long story short. She has got wet macula. Now, the wet macula situation she was aware of in one of her eyes, and the other one was dry. So the wet one was being treated. After a procedure which was cataract, the dry one turned wet. In May this past year, in '95, it came about because after the cataract operation, when she was looked at, she was told, after the month that had passed, that actually that one had turned wet as well. Now, the problem seems to be, and correct me if I'm wrong, but Southend Eye Hospital, and in particular the macular area, seems to be grossly overworked, if that's the right expression, and in chaos as far as appointments are concerned. Now, in this particular situation, obviously having turned wet, it was important that should be seen and treated as soon as possible. And with that in mind, the optician wrote to the hospital, which was sort of Southend, but there seems to be everything's booked through Southend, whether it's Allsit or Southend. So everything was notified, and as it happened, my wife was having treatment, an injection in the other eye, as a routine matter about 10 days afterwards. And the hope was that the hospital would try to have her attended to when she went to the Allsit, as it happens to be, to have her other eye done, injected, that is. But when she arrived there, nothing had been arranged. We had heard nothing, of course, and that is the other problem with Southend Hospital. You never hear anything, and we're in that situation where she couldn't have that eye injected because she hadn't gone through all the procedures in order for it to be approved. So this was in May. June went past, July went past, and we decided, look, we can't get hold of anybody in Southend Hospital. The routines had changed. There was a number you could ring before, but that doesn't work anymore. And so you just couldn't find anywhere where you could actually go through, ask the question, when will it be, or how long have we got to wait? So we went to PALS. And if I tell you we went to PALS 3 times, and 3 times we never got a call back from anybody at Southend at all. No call, nothing whatsoever, which I think's inexcusable when you're talking about 3 months have gone past, and despite all your efforts, you just can't get an answer. And so when my wife went to have that eye done again, in other words, the one that was the original problem, this was the end of August, and it had to take that staff nurse to go through the system to ensure that my wife got seen ASAP. And it was about the 18th, I think, of September, when eventually she got an appointment, which was actually at Allsit Hospital. And fortunately, the eye that needed injecting was done there and then. But I'm telling you, three complaints to PALS, nobody come back. Nobody come back even to say there was an appointment booked, nothing whatsoever. And that, I think, is the unforgivable thing. When you go through PALS in that situation and nobody comes back to you, they didn't even go back to PALS. No, it was just, if I say it was ignored, it was stuck on the in tray to be dealt with at some time in the future. Well, you're talking about somebody's eye who has got macular degeneration, as in the wet macular degeneration, which needs urgent treatment, you wait from May, June, July, August, September. I just think that really, in all honesty, that is unforgivable. And, we're in the situation now where eventually we've now got to the end of her treatment, and we're down to get an appointment in 3 months' time for everything to be examined to see how things are. I must tell you, I'm not holding my breath about 3 months, because the appointments that my wife has got for since last since spring last time, as it were, when her first one had the problem, it has never been less than 8 weeks, 10 weeks, 12 weeks, and that is for a 4-week appointment for macular degeneration injection. So there's something awfully wrong in the system. You cannot contact anybody. You can get onto a switchboard, and if you're lucky, they may be able to put you through to a department, or as my wife experienced today when she wanted to talk to the people at Orset, the switchboard operator says, look, you have to try another time, because they never answer the phone.
Danny.
Now,
Danny, I'm sorry,
that sums it up. I try to keep it as short as possible.
No, I appreciate that. I appreciate you've obviously gone through you obviously had a bad experience, and I can only apologise for what you've had to relay to us this evening, and I'm thankful that you've taken the time to do that. I'm just conscious that we've overrun slightly, but it's important sometimes to overrun to hear these sort of stories. And I thank you for sharing that.
It's okay. I think
it'd be important. I think it'd be important to pick this up. I mean, there's an email address in. Where's that email address? There's an email address in the chat. msc.patientengagement@nhs.net.
Sorry, MS.
It's MSC. Sorry. It's okay.
Yeah.
msc.patientengagement.
Right.
At nhs.net. Now, I'm not sure Sarah with the best one to advise is the best email address to email, but I'm sure Sarah can signpost you to try and get what you need for your wife.
Yeah.
But I'm really thankful for you raising this.
Yeah, well, I think, apart from obviously being personal to us, it's like let's put it this way, I am sure that some people, if you didn't remind them, and we had to remind them about all of them anyway, because, you get 4 weeks and you go, well, hang on a minute, we haven't even got the appointment booked yet. So you get on to somebody and then the line moved or got amalgamated with the switchboard, whatever happened, you couldn't get anybody then. The only way you seemed to be able to do anything was to get through to PALS. And PALS, to be fair to PALS, they tried their best. They just didn't get any response at all.
Thanks, Danny. And as Tony said, thank you. Thanks for your feedback. And the email address that I've provided, we will help to signpost. But some of that will be signposting to our PALS or our complaints team so that they deal with that process. And I completely understand that it's incredibly frustrating. I think just from very, very, very quickly, the I unit at Southend and Aldsett serves the whole population for Mid and South Essex. So as you can imagine, they have a huge workload, but take everybody's feedback on board. I think communication is a real clear theme, and we will I'll pick it up and I'll raise it in my meetings where I meet with our senior directors of nursing as well. So once again, thanks ever so much for giving me your time, for listening to me, but also enabling me to pick up some of the issues that are very clear. They're not acceptable, and it's not something that we will ignore, and we want to move to improve. So
I from my end do understand the pressures that you're under. So I just think that to share the information is helpful for you guys as well.
Absolutely, Danny. If we don't know, we can't help make improvements. So yeah, please don't apologise for sharing what our negative experiences, and let's hope we can make a difference for people in the future.
Well, thank you very much for listening.
everyone for joining. Sarah, thank you so much for
Thanks, guys.
giving up your free time this evening. Eve, thank you for facilitating as always. And thank you to everyone that joined. Have a lovely evening. Bye-bye.
Thank you.
Thank
Bye,
you very much.
everybody.
Bye.
Take
Bye-bye.
care.
Bye. Bye.
Thank you. Bye.